Leonardo is starting or Daniel is starting?
I'm going to start in the introduction, and then I will introduce the conferences, and then we'll start the conference.
Okay. All right, sir. We're live in 3, 2, 1.
Hello, hello, everybody in all parts of the world. Good morning, good evening, good night. I have the pleasure. I am Dr. Leonardo Guiloff from Chile. I'm an orthopedic surgeon. For people that doesn't know me, I'm working in this issue of regenerative medicines a lot of years, and I have the pleasure to introduce this 4th meeting webinar about shockwaves and other physics techniques that stimulate cells. And today, the main issue that we are going to talk is the use of this technology in bones. And I have the pleasure to introduce the best conferences that we can have in this topic I think in all the world. So I have the pleasure to introduce Dr. Wolfgang Schaden, that I think that is the most experienced orthopedic surgeon in the world in bones. Also, Dr. Karsten, so he is from, Dr. Schaden is from Austria, Vienna. Dr. Karsten Knobloch from Germany, that is orthopedic surgeons in hands and aesthetic surgery that has a lot of experience in this issue. Our president, I have the honor to present again to Dr. Moya, that is was the best surgeons in South America and regenerative medicine. We have also the pleasure to introduce our next president, Dr. Edson Serrano for Peru, that is going to talk also about this issue. And Dr. Hayong from Taiwan is a researcher that is going to talk us about a very interesting issue in cartilage. First of all, then I will ask Dr. Moya, that has a presentation recorded, about what is this thing of bones and shockwaves. What happened with this in the last years, Dr. Moya? You can teach us what happened.
Thank you very much, Leonardo. I will begin. Sorry, just a moment.
Mm-hmm.
Thank you very much, Leonardo. Yes. Good, just a second. It was working as usual, and now it's not working, but it will take a second and should work.
But the mystery is something important in this type of conference, Dr. Moya. So it's not a problem. We're going to be anxious to see what you are going to teach us today. Now,
thank you. I am happy to participate in this meeting. Fracture healing is a very unique and complex process with respect to tissue biological responses, since the bone is capable of regeneration, forming native tissue. To achieve this, it is very important to meet certain mechanical balance. This is called mechanostasis, and these are the conditions that imply the basic mechanical environment for the bone to be able to heal. After the fracture, a cascade of biological processes is triggered, including the participation of cells as endothelial cells, the ones we are seeing here, osteoprogenitor cells, platelets, macrophages, mesenchymal cells, and monocytes. Phenomena at a molecular level, including active molecules that will intervene in cell signaling so that the cell recruitment, proliferation, and differentiation will take place, together with changes at the level of the extracellular matrix, will end up in bone healing. This group of structures and substances constitute a specific functional entity called the bone healing unit. This unit is responsible for the physiological response that will lead to the healing of the fracture. Mechanics and biology are deeply linked. Cells are able to recognize their mechanical environment, and if stress and deforming forces in the fracture site are reduced over time, reaching a value between 2 to 10% with respect to the time of the acute trauma, the formation of the bone callus will evolve. If this does not happen and the deforming mechanical forces persist, it will evolve towards the formation of fibrous tissue that is capable of coexisting under conditions of mechanical overload with which the bony callus cannot develop. Mechanical conditions so will lead to the cell differentiation on one way or another. All of this has been integrated into the so-called diamond concept described by Giannodis. To achieve a good result, osteogenic cells, osteoconductive mediators, and osteoconductive matrix must actively participate in an environment of mechanical stability, thus determine bone union. There are several factors that can alter the process. If we begin considering the patient, there are factors related to age, to the sex. For instance, it is more common to have patients with non-unions in men, probably due to being exposed to higher energy trauma. Also nutritional status, addictions, for instance, starting with smoking, and comorbidities, either directly or due to medication with these comorbidities are treated. If we think about the fracture, the location is very important. We all know that even in the same bone, small variations in the location can determine different prognosis. The severity of the injury in relation to the level of energy of the trauma, and finally the state of the soft tissues, since, for example, an open fracture will determine a greater chance of non-union. Finally, the type of treatment, for instance, the effectiveness with which we perform it, and complications such as infection will have a great influence on the result. When the biological response stagnates, our problems begin. The epidemiological impact is overwhelming. The different reports range from 5 to 10% of the cases of all the fractures to more recent studies that refer to 2% of all the fractures. We must also consider the social and emotional impact. Among these patients, there is a higher rate of alcoholism and divorce, and a very important impact on the quality of life. Let's take a look to this study in which 1 corresponds to an optimal quality of life and 0 to be dead. We can see that the non-union of the humerus determines a worse quality of life than, for example, a patient with a type 1 diabetes, or being HIV positive, having a hepatitis C, or having suffered an acute myocardial infarction. We must take an exact dimension of what our patients who live with a pseudoarthrosis suffer. There is also an economic impact. A study done in the UK showed that direct cost per patient was between 7,000 to almost 80,000 pounds. It was estimated that 320 million pounds were invested annually in direct expenses alone. To this, we should add the indirect costs related to transportation, downtime, etc. There is also dispute about how we define a non-union. We could say that it is the absence of healing in the expected period. This is correct, but unspecific. We could also say that it is the cessation of cellular activity in the fracture site. Correct again, but impossible to verify in daily practice. The lack of signs of healing for 3 months is easier to verify radiographically, but very subjective. The FDA considers the absence of healing after 9 months, but waiting so long to make a decision can reduce the chance of treatment success. Finally, the United States Health Agency considers the absence of healing of 3 out of 4 corticals in 6 months, but it is controversial because it was extrapolated from information obtained from an experimental study in rabbits. In a publication last year, the Danish Trauma Association proposed as a definition that is that fracture in which a new intervention will be necessary to achieve healing. This great variety of definitions is also reflected in the lack of clinical consensus. In this work by Bandari, a survey was carried out among orthopedic surgeons, and we can see the dispersion of opinions regarding the time necessary to consider a healing delay or a non-union. Diagnosis can also be a problem. Sometimes we come across situations like this one. The osteosynthesis plate conceals the visualization of the fracture site. It would be very difficult to define with certainty how many cortex are really healed. The use of classifications reduces our margin of error. Everyone knows this classification of non-unions according to their radiographic appearance. We have also scores as this one, the RAST for tibia fractures. It has a good inter-observer coincidence and predictive capacity. Finally, there are factors that we cannot measure. Although there is still not a vast knowledge on this subject, today we know that there is a genetic predisposition to develop non-union. Perhaps in the future, studies like this one, which present a genetic dendrogram and a sequence of the factors involved in the healing process, will be able to predict our chance of success. Not surprisingly, there is also a lack of therapeutic consensus. It is very difficult in the face of so many variables to have homogeneous populations to draw conclusions. Therefore, there are not concrete recommendations supported by evidence-based medicine for any therapeutic procedure in the treatment of non-unions. This is why some wonder if the rise or fall of evidence-based medicine in relation to orthopedic trauma is really taking place. New treatment options have emerged at varying degrees of development. Of all these new methods, focused shockwaves are undoubtedly the oldest and most widely supported in the literature. After more than 20 years using shockwaves to treat patients, the results still amaze us. This is a case that was treated 18 months after surgery. It was a failed arthrodesis, and we can see here very clear the progression of the healing and the power of the mechanotransduction. However, in this recently published study that performs a historical and bibliometric review of what was being published on the subject in the last 30 years, including more than 800,000 non-union related articles in almost 800 journals. In the 10 most cited articles in that period of 3 decades, I did not find the slightest reference to the use of shockwaves. Obviously, we must do something different to reach the general public of orthopedics and traumatology. I am sure that this webinar today will be of great help. Thank you very much. Thank you very much.
Thank you very much, Daniel. This was an extraordinary conference as usual, and you have taught us the difficulty that we have not only to the definition of non-union, but also to introduce our new technologies in physical stimulation in the cell that I'm completely sure that people as Wolfgang has a lot of experience, and in his country, this technology, even if the literature doesn't mention this, in Austria, this is a very important technology. And please, I would like ask Wolfgang, how do you do this technology, your results? What happened in Austria? And with your huge experience, I will ask you to teach us your knowledge, please, Wolfgang.
Thank you very much for these nice words. It's really true. In Austria, shockwave therapy for the treatment of non-unions, meanwhile, is therapy of first choice. I will try to thank you, Danielle, for this great overview, especially for showing the impact a non-union has to a patient. This is really something important to know. We are dealing with serious incapacity of people. Hopefully, this whole webinar might help to introduce this technology to more people. Yeah, sorry, I have. Can you see my presentation?
Absolutely, it's okay.
Great.
And to hear you also.
At the very beginning, I want to invite all the audience to join us for the ISMSD Congress in Vienna, that this time will be hopefully a live event, 4th and 5th November in Vienna. So please try to block the date. I think it will be a very interesting Congress, especially because we missed 1 year of information. And I already can tell you, because we finished the review process 2 days ago, so we will have a really nice program. Now, first question, is there evidence to use extracorporeal shockwave for the treatment of non-unions? So when we started to have our ICCs, the instructional course, the certification course of ISMSD, it was 2016 when we looked at what kind of literature do we have. So we had 163 publications only dealing with bone and bone pathologies. I just, a couple of days, I did the same search. And now, as you can see here, we are dealing with 711 publications dealing with shockwave for non-healing fractures. And till today, practically all of these publications could show that shockwave are able to stimulate osteogenesis to help in fracture healing. I will just show you two quite nice publications in JBJS. One where we also worked with John Furia, where we're dealing with fifth metatarsal non-unions on the base of the fifth metatarsal, which is very often including athletes. So 23 in Austria received high energy shockwave in a single session and then a plaster cast for 6 weeks. And 20 patients underwent surgery in the clinic of John Furia with a intramedullary screw fixation and also a plaster cast for 6 weeks. Let's have a look on the results. 21 out of 23 healed in the shockwave group, 18 of 20 healed. So there is no difference between surgical procedure and shockwave. When we have a look at the complications, we would see that we had one patient with a small petechial bleeding where the shockwave was applied to the skin without clinical impact, healing within 2 days. In the surgical group, there were 11 complications reported, 1 refracture, 1 infection, and 9 person suffering from the symptomatic hardware that had to be removed. I think one of the best publications also in JBJS is by Angelo Cacchio. He formed 3 groups. In each group, 40 patients receiving two groups Shockwave, one at a certain energy level, 0.4 millijoule per square millimeter, and the second group with a different device, 0.7. Both devices are electromagnetic devices. That's the reason for the apply 4 session in weekly intervals. And he compared this to a third group that had the traditional surgical treatment, as we all know, all over the world, with removal of the previous implant and so on. You know the procedure. Let's have a look on the results after 6 months. We see we have 70% of healed in the first Shockwave group, the second, and 74. No significant difference. The same is true after 12 months, and after 24 months, all 3 groups had over 90%, 94, 92, and 95. So there was no difference in the bony healing rate. When we have a look on the function and pain, we would see that at 3 and 6 months, pain scores and function scores were significantly better in the Shockwave group compared to the surgical group. The surgical group needed 12 months, 1 year, and 2 years to recover to get at the same level where the Shockwave group already was after 3 and 6 months. Let's have a look on the side effects. In the Shockwave group, in both 84 patients, we had 23 patients with neglectable side effects, superficial hematoma, petechial bleeding with no clinical impact, not needing any further therapy. In the surgical group, 2 patients had a superficial infection, 1 a deep infection, 1 had a temporary paresis of the radial nerve, and 9 out of 42 suffered of chronic pain on the donor side and the pelvis. So we have comparable healing rate. We have less and especially less severe complications in the Shockwave group. We have a shorter sick leave. We have people are earlier back to everyday life, work or sport, and we have significant less cost. So as Danielle said, there is absolutely no understanding why this technology is not developing quicker, because we are speaking about knowledge that is 10 years old. So just for those who are interested to use Shockwaves themselves for their patient, we recommend as National Society and also as International Society and as ONLAD to use high energy Shockwave devices, focus devices, no radial pressure wave. And we have only evidence for electromagnetic and electrohydraulic sources. And the big devices that unfortunately usually can require sedation or anesthesia because the treatment may be painful. So what is recommended when you use an electrohydraulic system, 0.3 to 0.4 millijoule, a little bit more energy flux density for the electromagnetic devices. Usually 3 to 5 hertz can be used, the frequency of the shocks. For the electrohydraulic device, around 3,000 to 4,000 pulses are enough. Electromagnetic devices do a little bit more. And usually with an electrohydraulic source, we do a 1 single session and then wait 3 to maximum 6 weeks. And the electromagnetic devices perform 2 to 4 sessions in 1 week interval. What are the requirements to perform Shockwave? In my eyes, it should be performed by a surgeon who is also able to do the surgical procedure, because you need the knowledge about non-union, and this is a very difficult specialty, and this should be experienced orthopedic surgeon. So you need a trained physician, of course, an informed consent. We For the moment, we do X-ray. Perhaps in the future, we can also locate the non-union by ultrasound. There is a big development. We need kind of sedation or anesthesia. Very important is immobilization after the shockwave therapy, because we know that the initial part of healing is the ingrowth of capillaries. And those capillaries are crossing the fracture gap, and we want to avoid micro movement in this fracture gap. And that's the reason for very mobile, for instance, tibial non-unions, we even put an external fixator after shockwave therapy. What we also learned over the years is in long bones, a non-union gap from more than 5 millimeters is you don't have good chances to bring this to healing. And if surgical procedures are necessary, such as dynamization, removal of broken screws, you need an OR, of course. The follow-up treatment includes, as we said, we have to avoid micro movements in the non-union gap for, depending on small bones, 3 to 4 weeks, long bones 5 to 6 weeks, because then the capillaries are, the vessels are big enough that they move with the movement of the bone and survive. And this is the really important phase of healing. So it might be that physical rest is enough. Sometimes we need immobilization by plaster cast or orthotics, or in the lower extremity, no weight bearing up to an external fixator. We perform X-ray controls when we have no risk of fragment dislocations every 4 weeks, like after bone grafting and stable osteosynthesis. And after 12 weeks, what we learned is that the clinical symptoms are more valid than X-ray. It happens that after 12 weeks, you do not yet see a lot of difference in the X-rays, but when the patient has less symptoms, less pain when weight bearing, then you can be quite sure that the fracture, that the non-union is healing. In case of doubt, please perform a CT. MRI is not helpful for the diagnostic of a non-union in this phase. And usually we have the definitive result after 6 months. If we don't see a convincing result after 12 to 16 weeks, but we see an improvement, we also think about the second shockwave therapy. The contraindication are the same as for all high energy shockwave treatments with focused devices. It's lung tissue, it's the malignant tumor in the treatment area, not as the disease itself. The same is true for pregnancy. If there is if the fetus is close to the treatment area, we should avoid treatment, but the pregnancy itself is not considered as a contraindication. Yeah, these are some technical tricks that I want to show you, because if you do it, you should be successful to promote the technology. So the image identifiers should be in the same direction, then you apply the device. In hairy patients, it might be necessary to shave, because we have to avoid air bubbles in the ultrasound gel that we put, because the air bubbles are decreasing the energy, and this can come up to 50–60% of the energy that is lost due to air bubbles in the ultrasound gel. Then you can draw the fracture gap on the tibia, and at the end you put ultrasound gel and you perform the treatment. We have in Vienna, we started in 2005 with this kind of device, and for 3 years we monitored our patient. This is contingent with the other therapies that we do. Always, as already Danielle said we have double as much male patient than female. I agree with him. This is due to activity, sports, and motorcycle, and so on. Quite young, close to 50 years, and the mean age of the non-union was more than 11 months and 77 referring hospitals. And this should just give you an overview. We have around a little bit more than 80% of healed fractures. It's a bit different depending which kind of bone. The small bones in the hand are responding excellently. The scaphoid is for sure problematic, but nevertheless, we have an overall healing rate of 81%. Just show you two cases to the end. This is a midfoot fracture. It was a wide open fracture, needed plastic recovery with a free flap. And this was 6 months after trauma. And we applied Shockwave plaster cast for 4 weeks. And 3 months later, you see this solid bony healing. And the last case, which is very important because it's a young girl, 1.5 years after trauma, she was in the goal of a football team and broke her scaphoid bone, and she should have surgery, but the hand surgeon in our clinic knows that we are, of course, also offering shockwave therapy in those cases. And here you see after 3 months, it starts bridging, and after 7 months, we have solid bony healing and a pain-free patient. She's back in the goal of her team again. So to conclude, depending on which bone is considered, we have from 75 to 90% bony healing. We have no damage to nerves or vessels, no risk of inducing a generalized infection. This is the reason we also treat patients with osteomyelitis. It's a non-invasive therapy. It's absolutely more comfort for the patient, and it's more economic than surgery. We did comparisons. We will show the latest one during the Congress in Vienna, and we save between 80 and 95% of the costs. So due to this experience in the past, shockwave therapy is considered therapy of first choice in Austria for over 10 years. Thank you very much for your attention.
Thank you very much, Wolfgang, for your nice experience. I know, and also for me, we have a lot of questions, for, especially people that are using this technology, but we don't have chance in this platform to do questions alive by people that is hearing us. We have the chat, and if somebody wants to do some questions, we're going to do it at the last part, and also we will have a discussion in between us. But now there's other technologies that are introducing nowadays in the use in non-unions, based in physics stimulus that also are important to osteogenesis. And one of the stimulus is, that I'm very interesting also, is the electromagnetic pulse. And we know that in Germany, and Karsten Knobloch can teach us about this, they're using a combination of technologies to make the bone heal when there is a non-union. I will ask Karsten to teach us how is that experience. Is true that both technologies can help us even more than only shockwaves, as Wolfgang showed us? Please, Karsten.
Dear Leonardo, dear Daniel, dear Wolfi, dear friends, it is a distinct pleasure for me to give you a glimpse in a novel and a bit different biophysical technology called extracorporeal magnetotransduction therapy. You may know this gentleman. He's owning a Canadian and South African passport. His name is Elon Musk, and he, besides others, is producing some electric cars I do not own. However, his fuel station is called Supercharger. And to coin it, how I believe that shockwave and even the novel magnetic field or pulse magnetic field therapies is working is that these devices, by a way, supercharge your tissue to achieve higher, let's say, healing capacities. So in electromagnetic field, everything comes down to Maxwell's formula, where frequency plays a major role. And if you look physical wise, and before my, let's say, shockwave era, there were 10, 15 years of shockwave physics discussions on where to measure, how to measure, and so on. And the very same holds true now for magnetic fields. So if you look physical wise in a single EMTT pulse, you see a oscillating curve in a very short time frame. You see it is 100 microseconds, and there is some reason to believe and evidence that to achieve a biological response, a magnetic field has to achieve at least a threshold of 10 millitesla in a cell. So 10 millitesla threshold is needed to achieve a biological response in that given cell. And if you look in an EMTT pulse, within some 70 microseconds, you have 10 oscillations higher than 10 millitesla, just to give you an idea. And there are even recently a number of publications analyzing the work done in magnetic field therapy, in high ultrasound, therapeutical ultrasound perspective, and so on. And given or taken from that very paper published in 2019 for pulse electromagnetic fields, you see in a bone perspective, it appears that proliferation, differentiation, and even deposition in the extracellular matrix is modified by pulsed electromagnetic fields. And it appears that not only pathways like transforming growth factors, TGF, or bone morphogenetic proteins are stimulated, as you see on the left column, but also some anti-inflammatory action is taking place, especially on adenosine subtypes like 2A and A3. And this is, for example, just taken from one of these reviews showing the pathways which are involved when pulse electromagnetic fields are applied on bone tissues. So the ion channels in that perspective play a major role. And as you might know, there are differences in terms of ligand-gated, say, potassium or natrium or chloride guided ion channels. There are voltage guided, gated, there are mechanically gated, or even always open channels. And it appears that these pulse electromagnetic fields interact somehow with the cellular membrane and therefore influence, especially voltage gated ion channels. And as Daniel pointed out beforehand, it is supposed that EMTT is working on one mechanism called electroporation, and Daniel has showed it beautifully in the non-union as a, let's say, as a source for bone healing, is a so-called piezoelectric effect, which stimulates bone healing. So in the end, as of now, in the year 2021, believe that there are some intracellular and even in the membrane located effects how these pulse electromagnetic fields may cause some action. And there are physical-wise some differences, somehow the same, like in between radial pressure waves on the one hand and focused extracorporeal shockwave devices on the other hand. It's the same is in pulse electromagnetic fields, PEMF, and novel EMTT. And you will see this is a, let's say, a contrast physical wise in green, the highly oscillating EMTT impulse, and in blue, the slow oscillating PEMF cycle, which is, if you count it in seconds or microseconds, the EMTT is somewhat 40 times faster, and it's much more oscillating over time. So there are some differences. And in the market in the moment, there are a number of manufacturers providing both PEMF devices, as you see on the left-hand side, which can be characterized by a, let's say, power set, effective transaction power measured in kilotesla per second. Lower than 60, it's called PEMF. And if it's higher than 60, it calls EMTT. And you see some devices, and this is only there are even more devices on the one or the other group. So in November 2016, I just started on my own the very first treatment with a pilot device on my knee. This was the first female or soccer patient 6 days after with a patellar tendinopathy with the prior EMTT device, where I combined ultrasound guided injections, focused shockwave, and EMTT for patellar tendinopathy. Another young soccer player, ice hockey player, sorry, with a processus coroidius fracture, who received both shockwave and EMTT on that very point of time to accelerate bone healing. And by now there are some cohort studies out, like this published 2017 on tendons, on the Achilles tendon, where they did either conventional treatment with eccentrics and heel cushion, or the combination in addition with EMTT, finding a stronger pain reduction effect in Achilles tendinopathy. And as of now, and this is the topic of today, EMTT and ESWT, you might consider combining it. And we did a randomized control trial on tendons, on rotator cuff tendinopathy, where we did either 3 sessions of electromagnetic focused shockwave, or the combination of shockwaves, focused shockwave, and EMTT. And we could show in that randomized control trial that the combination in black columns, EMTT and ESWT, at 12 and 24 weeks in terms of pain reduction is double so strong in a way. So you increase substantially the known beneficial effect of focused shockwave, at least on painful shoulder tendons. So to always being a step forward, and that's in sports medicine quite attractive and intriguing, that best healing can be achieved even faster. So the idea of combining, I will illustrate with some cases. This is a national swimming athlete competing for actually Tokyo Olympic Games, suffering this greater toe fracture, as you see. Not a big surgical problem. However, it withheld him from training for the Olympics. So he came 600 kilometers from Munich to Hanover to undergo focused shockwave and EMTT treatment for 2 sessions only because of the long distance drive. And this is him before with the cone beam weight bearing CT scan, shockwaves, EMTT, 2 sessions, and you see 4 weeks later. So in between March 7 and April 4th, you see not a complete consolidation. However, clinical-wise, he was pain-free after 3 weeks. So he could train back again in the Olympic pool. Same holds true for this professional soccer player. He suffered an ankle ligament injury, and in return to play time, he suffered a bone edema on his talus. So we did the very same, combining focused shockwave, high energetic in that case, because it's a bone indication, plus EMTT to further enhance return to play time in this gentleman. Another case on the hand, scaphoid fracture, and Wolfie has mentioned that scaphoid fractures and humeral fractures are known to have the, let's say, the worst outcome in terms of shockwave overall bones. for a number of reasons, malperfusion and so on. So this gentleman underwent 2 surgeries with non-vascularized bone grafts. Both failed over 2 decades, and then he received 3 treatments, combined treatments, EMTT and ESWT, as you see here. He then underwent cone beam CT scan, and you see a nice consolidation with a artifact reductive or reduction scan with a metal algorithm with a nice consolidation of this fracture 5 weeks after, just published in Medicine. And our General Secretary of German Ligas, Martin Ringeisen, did the very same in a 35-year-old boxer, scaphoid non-union, 6 months after. He did 3 sessions, as you see, 0.3 with the electromagnetic device and 3 sessions with the EMTT, and a CT scan 8 weeks after with a nice consolidation of the scaphoid non-union. Another AUFA in the way case, in German it's a BG, with a failed metacarpal 5th fracture where antegrad Kirschner wire pinning was unsuccessful. Then a very, in my view, short plate was done in an AUFA German hospital. So the result was non-union, and he again underwent the same treatment. This was after 8 weeks after bone grafting, non-vascularized bone grafting with the non-healing. He underwent combination of EMTT and ESWT, and you see in between 6 weeks a nice consolidation, immediate 6 weeks in between, you see here in the CT scan. Another, and Wolfie showed us that following scaphoid, humeral fracture or humeral non-unions have the worst success rates. This is a 36-year-old female who was pregnant when she when she suffered a car crash with a delta V of 70 kilometers. She was sitting in the right back seat. So they decided not to do surgery at that point of time. She underwent combination of focus shockwave and EMTT, and you see it's only 5 weeks after the first treatment of ESWT and EMTT, and you see a nice and solid callus in this non-union, just published in Unfallchirurg. And last cohort series I want to highlight is symphysitis, where bone edema, and this is a problem in high-level athletes, especially in soccer athletes, very problematic, long time to return to play, oftentimes 6 months or 12 months or even longer. So even doing shockwaves and EMTT or EMTT alone, and this is a cohort from Martin Ringeisen and Ludger Gerdes-Meyer again, where they did only EMTT, showing time pain-wise a significant reduction even after 4 treatments with the EMTT, completely non-invasive, completely pain-free with the EMTT device. And there are even some of the cases where they followed it by MRI. So the bone edema, which you can appreciate here on the left, symphysis is markedly reduced after the EMTT. So this is just giving you a glimpse that it might be that we can even achieve better success rates, especially on problematic long bones like the humerus or on scaphoid, or in athletes where we want to achieve even faster return to play. Thank you very much.
Thank you very much, Karsten. Very interesting, your conference, and I think that the questions are growing in all our audience, also in me. So we have to expect the last part of this conference to initiate the discussion. So, but we have another questions about bones, and we have another experience in these questions. We also know that in bone edema and in bone necrosis, this technology that produces angiology and vasculogenity can change the prognosis of the pathology. And Here in South America, my friend, Dr. Serrano, can tell us how has been his experience in this. Please, Edson, tell us what is your experience in this?
Thank you, Leo. It's a great honor to stay here with you to share my little experience in this kind of disease. Bone necrosis, strictly speaking, is death of bone.
Excuse me,
you can hear
your
me.
screen is not complete. Please open your screen. All the screen.
Okay, sure.
The full screen.
Okay, let me see. Yeah, it's good.
That's
now?
it. Thank you. Thank you, Edson.
Okay. I am saying bone necrosis is death of bone. Usually, the most frequent bones that is the femoral head, after that humeral head. But for the most frequent is the femoral head bone necrosis. I will talk only of this pathology. The definition of this condition is a disruption of the circulation of the blood flow of the some part of the femoral head. This causes death of the osteocytes and joint degeneration. It's very common. It's more frequently in males, and can be is the cause of the 5 to 20% of total hip replacements in USA. The most frequent of this etiology could be traumatic and not traumatic. Not traumatic is the most frequent is corticoids for steroids. Another disease are relations with this pathology: alcoholism, sickle cell anemia, another genetic diseases. The more frequent is for the steroids, especially in patients that who have used more than 20 milligrams per day for prednisone, for example. The diagnosis is the most important is the clinical evaluation, but it's very important to perform when we suspect bone necrosis MRI, because another proofs don't help us so much in earlier stages. X-ray in initial stages could be normal. For this reason, it's better to do MRI. Is the gold standard to establish the diagnosis.
Edson, excuse me, Edson, your slides are not running.
No running.
No running your slides. There's only the presentation, bone necrosis, and afterwards, no, the slides are not running. Please, please.
Let me see why not.
So you can advance the slide that you are now.
No.
If you cannot put this full screen, continue, but with not the full screen, but the slide must be running.
Now
you have the new slide, but I don't know if you can continue showing the other slides.
Let me see. Why not this screen? Yeah.
If you don't have the full screen, you can show us the half of the screen, but you have to continue with the next slide and the next slide, please.
Okay. I am here.
Yeah.
I am talking,
continue.
but
Okay.
MRI must be performed in patients we suspect with this pathology because the X-ray in its initial stages could be normal. MRI can show us a small bone depth, like in this image. The classifications are there. There are many classifications, but the more usual is this ARCO that in 219 was revisited, and this classification in ARCO 1, X-ray is normal. ARCO 2, radiograph evidence sclerosis, osteolysis. ARCO 3, we can show us the X-ray can show us subchondral fracture. But in these cases, it's better to do PC or MRI to see better. ARCO 4 is when the femoral head is collapsed and there is evidence of osteoarthritis. In this article, show us published in Bone and Joint Surgery last year, show us the different kind of treatments in every stage. The non-operative treatments are membrane restrictions, bisphosphonates, anticoagulants, vasodilators, and extracorporeal shockwaves. Rate of recommendations are E. But most widely diffused treatments are cordless compression. In this article, the rate of recommendation of cordless compression is A. Cell-based therapy, like bone marrow cells concentration and other kinds of cells therapy, or mesenchymal cells like, are in rate of recommendation B. But, however, when we review shockwave therapy in these articles published in 218, we can see the hip survivors in 81% and 95%. With this, however, cordless compression is the most most recommended treatment. The shockwave could be a good treatment. I can show some articles that talks. I think the most evidence when show us shockwaves works very well in this pathology. You can see this article published for Wang in 2008. Extracorporeal shockwave therapy shows your regeneration in hip necrosis. This article is performed in 14 femoral heads. In seven of these patients who received shockwaves prior to surgery, and in the control, 7 patients don't receive any treatments that they perform total hip replacement. In this article, this perform histopathological features that can show hip regeneration, bone regeneration in this kind of patients after hip replacement. There are many articles like systematic reviews. This meta-analysis can show the potential of shockwaves therapy in osteonecrosis in femoral head, can conclude for patients in early stage 1 and 2 stage, extracorporeal shockwaves can be safe and effective to relieve pain and improve motor and function. But I think this article is the more important that can demonstrate the effect of shockwaves in this pathology. long-term results of extracorporeal shockwaves therapy and descorporation in osteonecrosis of femoral head with 8 to 9 years of follow-up. In this article, the published for Wang, compare in 29 hips receives extracorporeal shockwaves and 28 hips receives core descompression. It's compare extracorporeal shockwaves with core descompression. Inclusion are ARCO 1, 2, and 3 early 3 stages. The demographic characteristics of the patients are similar, compare in both groups, the shockwaves and surgical groups. The shockwaves applied with a big machine, high energy, with help with fluoroscopy, with one protocol establishes, and core descompression have another protocol. Comparing after that of this finishing, you can see in shockwave group surviving hips are more than surgical group. You can see surviving hips in shockwave groups are 22 and in surgical groups 10 only. Number of total hip replacements are more in surgical groups, 64% in compared to 24% in shockwave groups. It's similar results in pain, similar results in lesion in images. The shockwave groups have better results. You can see the images in this picture at 6 months, 12 months, 24 months. In edema, is similar. Conclusion is in the surgical groups, the mobility of the donor observed in 16 hips, 58%. There are no infection of deep vein thrombus, but in shockwave groups only can see swelling and in the site. Conclusion: shockwave is more effective than core descompression and bone grafting in early osteonecrosis of femoral head with this article, but these shockwaves must be with high energy equipments to perform very good treatment in the femoral head. This treatment must be performed under, in our case, for kind of the equipment that we use sedation by anesthesiologists, and actually for the information that I showed, we perform core descompression, cell therapy, and plus shockwave treatment. I can show you some 3 clinical cases. The first is 38 years old. He came with me in 2014 with this compromise. You can establish in stage 3 or includes 4. You can see the MRI. We perform core decompression with cells, bone marrow concentrate. After that, we perform shockwaves like Dr. Schaden teach us. Until now, 7 years after, these patients don't want to perform a total hip replacement. He have problems with hip, but we can delay the hip replacement his ongoing following after 7 years. Another case is a male for 43, engineer. You can see is a great stage 3. In these images, you can see the subchondral bone fracture. We performed a shockwave before 1 month before the surgery. We performed core decompression with stem cells. And 1 year after, you can see, and 1 year after the surgery, you can see the track of the sign of the core decompression. The patient is still with the pain is decreased with can perform normally through daily activities, but he don't want to perform hip replacements too. Now is the last. He have 2 years of following of this patient. You can see is 2 years, and the final patient is a male, 33. Both hips, you can see the right hip is a stage 4, needs a total hip replacement, but left hip have a stage 3. First, we treat the left hip because after that we perform a total hip replacement in right hip. In left, we perform mesenchymal stem cells, core decompression, arthroscopy, and with cell therapy. And then we perform a shockwave. After that, we perform total hip replacement. With these patients, we can show us the treatment depends of the stage of the illnesses in the patients. The conclusion as hip or groin pain in adult suspecting osteonecrosis, we must to suspect to perform early diagnosis. If possible, if it's possible, preserve the femoral health. Always thinking about in bilateral. Shockwaves are safe and effective treatment. We use like coadjuvant treatment like with cordless compression. The evidence for cell therapy is increasing. Nothing else. Thank you very much for the opportunity. I'm very happy and very honored to stay here with you.
Thank you very much, Dr. Serrano. Very interesting, your conference. And we saw that you have a trick because there was Wolfgang helping you. So it was a very good idea to do this presentation. But we are continue having a lot of questions. So I think that we must wait the last conference. That is something that for me is really very, very interesting. We have now here from Taiwan, Dr. Hyong, that have an experience that everybody of us would like to know. Until now, we are saying that cartilage is the most difficult treatments that we can do with every technique. And we all know that that cartilage bring us always to some surgery, but he's doing, as you see here, a preclinical study with shockwave in osteoarthritis of the knee. So we would like to ask Dr. Hyong Cheng to tell us which was the results with cartilage. This is very amazing. Please, Dr. Cheng, tell us, we can use shockwaves in the preclinical study in knee arthritis?
Thank you, Leonardo. Can you hear me?
Yes, perfectly. Thank you very much. Yes.
Thank you. Okay, today my topic is the Shockwave therapy in knee osteoarthritis, the preclinical studies. So let me briefly introduce the osteoarthritis for the audience. So we know the osteoarthritis is a multifactorial disease and caused by many risk factors, including aging, excess loading to the joint, trauma, infection, overweight, and metabolic diseases. So knee osteoarthritis is often to see the osteoarthritis disease in our joint. So according to the Kerran-Lawrence grading scale, we can see the knee osteoarthritis can be divided into 4 grades. So in the grade 1, you can see this X-ray film. So we can see the downfall joint space narrowing and possible osteophytic lifting. And in the grade 2, we can see the deafening osteophytes and possible joint space narrowing. So in the grade 3, multiple osteophytes, deafening joint space narrowing, cirrhosis, and possible bony deformity can be found. And in the grade 4, large osteocytes, joint space narrowing, severe bone cirrhosis, and deafening bone deformity in the media. So what's the Shockwave therapy and how it can be used to treat the knee osteoarthritis? So here you can see Shockwave is a non-invasive scoring way with high pressure and high energy. And the Shockwave is subject to the physical laws of reflection, diffraction, and absorption. And as 99% of the Shockwave is reflected as any air bubble, so it needs to be covered with the ultrasound gel to transfer the energy into the patient's body. So according to the ISMS guidelines for the Shockwave therapy, several effects on tissue could be detected, including thermal and chemical effects, biological effects, mechanical transduction, gene expression, and magnetic tissue response, macroscopically recognizable healing, and hyperstimulation anesthesia. So audience can search the ISMS website and download the ISMS guidelines to read in detail. So we know the Shockwave therapy can be used to treat the knee osteoarthritis in clinical treatments, and many systemic review and meta-analysis lecture you can search in the PubMed. And all the evidence show that the Shockwave therapy is efficacy and safety. So the outcomes of the Shockwave therapy are measured in pain relief and physical function improvement in patients with knee osteoarthritis. But here we have a question. What are the pathological changes and molecular effects after Shockwave therapy on the human knee? So we use the red model to illustrate the pathological change and molecular effect after Shockwave therapy on knee osteoarthritis. We use the arterial cruciate ligament transection or arterial cruciate ligament transection with medial meniscectomy to create the knee osteoarthritis in animal model. And we apply the Shockwave at the energy flow density 0.18 to the 0.25 millijoule per minute squared to proximal medial tibial condyle to treatment the red knee osteoarthritis. So our supervisor and teacher, Professor Cheng Wang, he started animal study and published 3 lectures in 2011 to 2012. So the results show that Shockwave therapy has control, protect, regression, and time-dependent effects on red knee osteoarthritis. And we also can find Shockwave enhance the expression of type 2 collagen in articular collagen and enhance the VEGF-BMP2 osteocalcin in the subchondral bone. So in the 2016, we had a microRNA study. So we use next generation sequencing method to identify the microRNA from the articular collagen and subchondral bone after Shockwave therapy on knee osteoarthritis. And we extract the total RNA from the sham osteoarthritis and osteoarthritis after Shockwave therapy. And we identified 69 significant expression profile of microRNA and upregulation or downregulation in the articular cartilage and subchondral bone. So next, we have a prediction and analysis the effective gene by microRNAs in the articular cartilage and subchondral bone before and after Shockwave therapy. So we found the effective genes of microRNA are correlated with ion binding, transcription and translation, NTP binding, signal transduction, and cell differentiation. So in 2016, we had a proteomic study, and we used the two-dimensional electrophoresis from the healthy control osteoarthritis and osteoarthritis after Shockwave therapy. And we x-rayed the protein and found the significant protein can be expression after Shockwave therapy. This protein is the PDIS3. So PDIS3 play a key role in rapid membrane signaling in osteoblasts. Here you can see the pathway. And this protein is correlated with the vitamin D intake. And it could be involved in the bone formation and cartilage repair after Shockwave therapy. And here we published the paper all applied the Shockwave on the plasma medial tibial condyle. So question here, is medial tibial condyle the best location for Shockwave therapy? So we published 3 lectures to discuss this issue in 2017 to 2019. So here you can see the pathological change of articular cartilage. And in this cartoon, we apply the Shockwave on different locations of the knee osteoarthritis in the animal model. And we also apply to the meniscus and direct to the articular cartilage to see the effect. And this is the macromorphological photographs. And we can see the surface damage of articular cartilage. So in the gross pathological lesion score here, you can see Shockwave applied to the medial femur and tibia is better than other locations. So next, in the suffering stent, we observe the damage of the articular cartilage. And also you can see Shockwave applied to the medial femur and tibia is better than other locations. So next, we want to see the pathological change of the subchondral bone, and we use the micro CT to analyze. And you can see we analyze the bone mineral density, bone volume, bone porosity, and trabecular bone thickness and trabecular number. So here we found according to overall result in micro CT analysis. So the medial femur tibia is better, a little better than the medial tibial condyle, and much better than other locations. So in the molecular effect in articular cartilage, we analyze the tunnel activity. This is a apoptotic marker. So in this result, immunological staining, so we can see the Shockwave applied to the medial femur and tibia can suppress the tunnel activity than other locations. So this is the proliferation cell nuclear antigen, and we can see the cartilage proliferation. So according to this result, you can see the femur Shockwave applied to the medial femur, tibia, and tibia is better than other locations. So next, we can see other molecules. The DMP1 it can be enhanced after Shockwave therapy to the medial tibial condyle and suppress the MMP13 and AMTS5. So here we had the effects of the locations for Shockwave therapy. And we apply to the different locations and use the ultrasound guiding. So the conclusion is the Shockwave applied to the medial femur and tibia is better or equal than the medial tibial condyle and better than other locations. So in the summary, here in the animal study, so we know the Shockwave therapy has control protected regression and time-dependent effect on Renin osteoarthritis. And we use the next generation sequence method and found the 69 significant expressive profile of the microRNA after Shockwave therapy on Renin osteoarthritis. And in the proteomics study, we found a significant protein, PTIS3, can be enhanced the expression after Shockwave therapy on the Renin osteoarthritis. And this protein is involved in the bone formation. So in the locations study, we can see the Shockwave applied to the medial femur and tibia is and the medial tibial condyle is better the therapy, and the result is better than other locations on the Renin osteoarthritis. So in the molecular effect, we can see Shockwave can enhance the expression of type 2 collagen, PCNA, DMP1, and reduce the expression of tunnel activity, MP13 and ATMTS5. And in the subchondral bone, Shockwave enhance the expression of VGF, BMP2, and osteocalcin. So thank you for your attention.
Thank you very much, Dr. Hai-Hong. Now we are finished all the conferences, and I think it's the most important part of this webinar that we can begin the discussion. And I would like to begin the discussion with some questions that we have here in the chat. We have a question from Sapriya from OrthoTV that is asking, I think that to all the conferences, how is transcutaneous shockwave therapy? What will be the alternate for it? I don't know if which of you would like to answer that question. Dr. Schaden, for example.
Do not really understand. I do not really understand the question. Should mean perhaps transcutaneous shockwave therapy, and I would say this is the definition of extracorporeal. We use our shockwave devices and we apply the energy to the area where we want to deposit the energy through the skin. So all our treatments are extracorporeal transcutaneous therapies.
Maybe I can jump in Innsbruck. Actually, there is a clinical study performed by Johannes Hohlfeld and colleagues who are performing shockwaves directly on the open heart. So, maybe the question was guided in that direction. I don't know. However, you can achieve in a way, at least with focus shockwave, far deeper tissue levels. And there is not always the need, for example, to directly go through the sternum in heart surgery. However, if you undergo heart surgery, you can directly go there. However, there are still some colleagues in Switzerland doing transthoracal shockwave therapy for cardiac purposes with through the thorax. So I have difficulties with this type of question as well.
Yeah, thank you, Karsten. I would say that the approach directly to the heart is because they try to avoid lung tissue.
Right.
So the other approach is substernally, where you can come to at least to the apex of the heart through the abdominal area, and you avoid lung. But this is a good explanation. It might be that this is the difference to all the other orthopedic indications.
I don't know if Dr. Hai-Hong, that is that are making investigation of these problems, have some idea about what Wolfgang tell and Karsten. You would like to add something, Dr. Haihong?
Yes.
Or what do you think about transcutaneous shockwave therapy?
So what's the question?
We were discussing about transcutaneous shockwave therapy. What do you think? It's something applying directly, as Karsten tell us, directly in the heart, for example, or what is or directly in the tissue? What is your idea about the question, or you don't have anything to say about this?
Sorry, I don't have a clinical any experience for this.
Okay.
This study.
Okay.
Maybe, Louis, I might add, there are 2-3 studies doing, because Edson is doing some PRP, bone BMCS stem cell therapies. They applied shockwave therapy on the syringe where the PRP is in, and they could improve their PRP result in terms of transforming growth factor and platelets by some 200%, published 2-3 years ago with focused electrohydraulic and with the electromagnetic device. So there is even, you know, just to get the idea very wide, the idea to improve your agents, maybe with the help of shockwaves, extracorporeal and directly on the syringe.
The syringe. That's okay.
I think, Leo, can I see something?
Yeah, sure.
I think it's a terminology. I think transcutaneous, some people try to say extracorporeal shockwaves. Is how use the terminology, but the appropriate terminology is extracorporeal shockwave therapy. And something about the Karsten, the concept is there are many publications about the use shockwaves after apply some kind of cell therapy, like PRP or bone marrow aspirate concentrate. After of this, like we apply in femoral head, after 1 day after the surgery, we apply shockwaves. Some reports said about these mechanical stimulates can improve the cell growing, the cell differentiation, and can be better the treatment, the surgical treatment after that.
Well, okay. If somebody have to add something about this answer, or Daniel, you have something to say about this? Nothing. So we can.
I can. My experience. So I think the shower combination therapy is a good way to think. Combine with shower or shower combined with steel therapy. I have the animal study for the red knee osteoarthritis, and we published the paper this year or next year. So I think the combination is good for only for the shower therapy. So as the Dr. Serrano say, if shower apply to the PRP or stem cell, it can activate some platelet or the stem cell and have a better effect on the tissue. So this is my opinion. So shower therapy can combine other therapy. It's better only one shower therapy. Thank you.
Okay, so you recommend to combine to active the cells to combine the technologies. That's what we can understand. What do you say, Ihom, in your research?
Yeah,
it's a good idea to combine shockwaves to the PRP and to the cell treatment.
Yes, we know the some literature say shockwave can activate the stem cell or PRP. So we can inject the PRP or stem cell and then apply to the shockwave, and this can activate the stem cell to our tissue.
There are some studies that also talk about laser in activation of PRP. You have some experience about another activators of the PRP, for example, that are not shockwaves?
We use the adipose stem cell combined with adipose stem cell for the osteoarthritis in the rat model.
Okay, yes. Okay. Well, if we don't have other comments about this, there is a second question, but I think that this second question is not a good idea to discuss it because it's about the costs of the machines. And I think that this type of webinars is not to discuss about some costs of the machines we use. So I think that we can give an answer about this, and it's not the opportunity. I think that you can know the type of machine, and each of you that have some doubts of the cost has to ask directly to the factories. So we should continue. We should continue to doing the next question that is recent made. Is ISMST and digest do not recommend apply SVT in osteoarthritis because there's no clear data to prove their efficacy. So is there any sense to do so for relevant patients or not? I think that this question can, please, Karsten, begin the discussion, please.
So as a current president of digest, I can tell you that our guidelines, which were approved in a common consensus based on available evidence, were done 3 years before. So as you appreciate, every day, nearly every day, there is a single new paper. So we have some 300, 350 papers on ESWT every year. So the evidence on, let's say, an indication like osteoarthritis, both from a digest and from an ISMST point of view, is evolving. And on the ISMST, we come together next time in Vienna and we will discuss whether or not osteoarthritis should remain at that point of time still an expert indication or might advance to another, let's say, advanced indication state based on more solid evidence. But this is only done, not for a single study or for a single case report, but for solid, at best, meta-analysis and randomized controlled trials. So it takes some time for guidelines, say 3, 4, 5 years, to come up with the current trend, which is seen in literature. And then there is even a discrepancy from literature published in PubMed and what is published, for example, or presented at the ISMST meeting, where oftentimes we see papers well before publication. So you will see in Vienna some papers which has not been find their way on PubMed now, still very, very good papers, however, not published yet. So in the end, from a scientific point of view, it really takes some time. And especially if it comes to societies like DIGAS and ISMST, there has to be consensus. And therefore, we have to meet. And before, due to COVID, we could not meet for, let's say, 2 years time in the end.
Wolfgang, I will please, I will add to the question another question. You have some experience in osteoarthritis and ESVT, your personal experience in Austria?
Yes, I do have. We have now critics because our recommendations are not completely equal to literature and evidence. Just give you an example. When we founded ISMSD in 1997, I knew every publication on shockwaves. I kept this till 2003. I could say I knew everything that was published concerning shockwave and orthopedic indications, even basic research. Now it's impossible. But also in those days, people asked the experienced researchers, what would you recommend? So our recommendation always was between evidence-based literature, personal experience, and case reports. And I think this is a part of a scientific society in a very evolving technology, that the experts judge evidence, personal experience, and reports. That's the reason for the ISMSD encourage people to present case reports. For instance, in the big orthopedic societies, you are not allowed to present a case report because it's not evidence-based. We encourage people because we have a different approach. And this is the reason for shockwave therapy developed from the 4 old indications: tennis elbow, calcification of the shoulder, and plantar fasciitis, and non-unions, to heart, to spine, to nerve tissue. So I would say, when all these people are sitting together, we see, now osteoarthritis has more and more evidence, and we'll move it from one step to the other, from expert indication to commonly used, or whatever is necessary. And I think the statement is not right to say we do not recommend, but we do not yet recommend it as a standard therapy, because we recommend it as a standard of therapy. Then we have to have class A evidence. Then we would say plantar fasciitis, no doubt. Non-unions, no doubt. This should be the therapy of first choice. We even published such an article. So it's not black and white, but we have all the different stages. And this is the reason for we have different stages of recommendation. And I think this is a quite rational way how to treat exactly this kind of questions.
But I ask you, I add to the question, what is your personal experience? What do you feel about this? It's not an evidence A. We have our own experience, and I think that is very important to know that.
Due to my experience, early stages of osteoarthritis respond extremely well to shockwaves. Shockwaves are not the solution. We have so many, as Edson showed, so many influences of osteoarthritis, like the axis of the leg. So we have to correct this as well. If we are not fighting the reason for the pathology, shockwave cannot heal it. If you have a varus deformation, you have to work on that as well. So in combination with orthotics and shockwaves and other physical therapies and other approaches, I think shockwave is an excellent tool to delay surgical procedures. And this is something that we want to, because if we are able that people do not live as long as their knee needs a total replacement, this is good for the health system, it's good for the patient himself, and so on. And the later you get a total joint replacement, the higher the probability that you don't need the second one, which is always a big challenge. So I think to delay this time, shockwave will develop to be an excellent tool, but it's not the only solution. I have patients, for instance, with wrist arthrosis, women working in their gardens, always at the end of the summer, when they did the garden work, they have pain, they need anti-rheumatic drugs, and they come for 2 or 3 sessions of Shockwave, and then they say, my whole winter, I come through it, and before the garden work starts again, they come, have another series, and say, this is the way I could reduce my anti-rheumatic drugs. You know, it's not the solution, it's not to heal a pathology, but it's a possible tool to help your patients. I would personally, not evidence-based, recommend to think about Shockwave when you are treating patients with early stages of osteoarthritis.
Thank you very much. In honor of time, Daniel, please. Daniel.
No, I completely agree with the explanations by Karsten and Wolfgang, but I think that seeing this from the side of people that has no experience with shockwaves, sometimes the image is a little bit confusing, because as Wolfgang said, it is true, there were few indications, there were few papers, and was easier to give an opinion, but the general doctors, the general orthopedic surgeons, perhaps with no experience on shockwaves, are receiving now many indications, multi-treatment, that a patient is receiving cells, EMTT, shockwaves, focus shockwaves, radial shockwaves, PRP. The patient is crossing his fingers, is praying, and you don't know what cured the patient. So I think that we need to be very clear about that, especially for massive information. And sometimes I think it's a little bit confusing why a professional of health choose so many treatments at the same time for one patient. For me, I think it's a point that should be discussed and make clear. And I agree about trying to win time to delay the indication of surgery for osteoarthritis, but there are some joints in which it could be a problem. For instance, shoulder, because hip, you can wait for a long time, and you will not have big differences with the technique. But the glenohumeral joint will have posterior dislocation, erosion of the glenoid, and the arthroplasty would be in the future perhaps more complicated. So I completely agree with wrist arthrosis. I completely agree with knee surgery, with hip surgery, but unfortunately in shoulder we have that problem. You can make a revision of an arthrodesis of the hip and put a prosthesis, but with shoulder surgery, shoulder joint is not so easy to deal with that. That's what I wanted to say.
Thank you, Daniel. So in conclusion, we must say that we don't have the complete answer in osteoarthritis. I think osteoarthritis will continue being a challenge for everybody of us. All these type of treatments are something to delay the production of the pain of this terrible disease. So we must continue doing our efforts to put in order what we are doing, as you say, Daniel, and in the future we can have the best or unique technique or combination of techniques that can delay this type of pathology that is progressive and until now not solved. So we have to have this idea now in 2021, not to say or to think that with the research until now we have the answer, because we don't have it, but we are advancing in this pathology and we have good delays in some joints, not in all. So we must continue doing the effort to help to the people not to have artificial joints always, because unfortunately, this pathology is very, very spread. In the United States, for example, 95 millions of people, in the last paper that I read, have osteoarthritis of the knee. So, and they are young people between 18 and 65 years. So we must continue fighting to delay the prosthesis procedure in that young people. We have another. I don't know if you want to say something else, but in honor of the time,
Leonardo, yes, we are on time. I will answer the last two questions, and because we are on time.
Okay. Very short then. There is a question about the knee disc. Say that we can use shockwaves in disc nation because there are some countries that are using it in the eastern part of the world. Some of you have experience in shockwaves in NA disc in discopathy.
Actually, in selected cases, which are not neurosurgical ones, I did it, and I'm aware that Thomas Nedelka in Prague does it on a very high number of level, in the idea not to treat the bulging disc, but to treat the nerve. And we are aware that shockwaves can enhance nerve regeneration, both for the axon and for the nerve sheath. So if you are aiming, and this is done only by focused shockwave because you have to go deep near to the spine, then the idea is to, enhance the nerve healing without any changing of the disc or the bulging disc. That's the idea we have at the moment. There is no data out there yet, for sure. So it is more or less an experimental or even less indication. However, the let's say on the cases we receive from different countries, like from the former Soviet Union and myself, and from Prague and so on, it appears that this might be an idea where we go for. However, it's the same like for the different stages in osteoarthritis. So it really depends on the lumbar spine or the cervical spine, on adverse effects, say, of a surgical intervention on the cervical spine or lumbar spine is quite different, as you know. So these all play a role. However, in the future, I see that maybe since the peripheral nerves benefit from focused shockwave in the moment, it might well be that for some certain instances, even in bulging discs, it might be an option. Yeah.
Thank you very much. Very short, only a question for Professor Hayon. You have some research, doing some research, preclinical research in this type of cartilage as the disc cartilage, Dr. Hayon, as you have done in the cartilage in the knee?
No,
nothing. You have done any type of research about this? Because if we don't have the research in this special type of cartilage, we can know which will be the biological aspect that we can change in the disc. That's why the question is only a minute, Wolfgang. You don't have any research in that?
I don't any experience for the clinical treatment. So I only do the animal study. So I don't have no idea to answer this question.
Okay, Dr. Schaden.
The target is not the cartilage. The target is the root of the nerve. We know that we have an effect of modulation of the inflammation. The neuroinflammation is the bad thing. The swelling of the nerve, this is causing pain and self-damage. And there are some evidence, that's the reason for we are now in a clinical study to use shockwave in spinal cord injuries, in fresh spinal cord injuries within the first 48 hours. because we could see in clinics and also in humans that there is a good influence on the neuroinflammation. The neuroinflammation that really does the damage within the first 10 to 14 days. And if we can modulate this process, we could show in CTs and MRIs that the damage is significantly less when you apply shockwave in an early stage. And I could imagine, I have no personal experience with disc prolapses, but I could imagine that this effect on the nerve might have a certain pain relief and might, but I would not yet, with the data we have, recommend the treatment.
Okay, I think that in honor of time, we have to continue. I know that the questions are not being completely answered, but this might have make us to do another webinar about this very interesting issue, but we should continue. And this is the very controversial question, because this question is about the radial pressure waves. They want to know, is radial pressure waves have something to do in delayed unions in bones, or is some paper of this of his efficacy, and also with fresh fractures? I think that I would like to hear Wolfgang first, telling us what do you think about radial pressure shockwaves in non-unions, Wolfgang?
No, we know that there are some publications out showing that there is a certain possibility to promote bone healing also with radial pressure wave, especially from Brazil, also from other countries where the focused shockwave is not available. It's too expensive or not available. I would say, as a scientific community, with the data we have now, we cannot recommend to use radial pressure wave for bone indications, because the results are less good than with focused shockwave. And what we know is, as Danielle showed us, we are dealing with really important pathologies. People are suffering. And as I bring it always in the instructional course, of course you can treat a femur fracture with two cerclage, with two, and not with an intramedullary nail, because you don't have it. But a K-wire also can hold a certain stability, but it's and this is the same compared focused shockwave big device to a radial shockwave for a femur fracture is like choosing between an intramedullary nail and two K-wires. Both will work, but one will work solidly with a high chance of healing. The other, you have to be lucky that it heals. This is, for me, it's a clear case. And the question for fresh fractures, I think this would be a question for Taiwan, because Professor Wang, he showed that when you apply shockwave to immediately after the surgical procedure in high-speed fractures of long bones of the lower extremity, you have less rate of non-unions, half of it, and you have earlier full weight bearing. So it might make sense to apply focused shockwaves also in fresh fractures, but as I always said, now we are here to convince people to use it for non-unions. At the moment where we would start to recommend to use it for fresh fractures, the social insurances would ask if we are crazy. It's an economic reason not to recommend it, but there is a good paper out from Professor Wang who showed, yeah, the patient would have a profit, but it's only one publication. That's the reason for also the International Society and the biggest are not recommending the use for fresh fractures.
Well, I think that everybody of us, I think, agree with Wolfgang we have, unfortunately, we have to finish this webinar. I think that this topic is very, very interesting. So I will ask Daniel that are organizing these webinars, that if we could have another webinar discussing all these issues, because this is a very dynamic, and I think this is the most important topic in Shockwaves nowadays, to discuss these topics. Thank you very much to Professor Schaden, Professor Serrano, Professor Moya, and Professor Knobloch, and Professor Hihong, to teach us so much about the use of these technologies in bones. And I will invite all the audience to continue following us in and also to Orthopaedic TV, OrthoTV, to let us to do this type of webinars. And I hope to see you, everybody of us, personally, as soon as possible. Very good luck to everybody, very good health to everybody, and thank you very much.
Thank you, Leonardo.
Thank you. Bye-bye to everybody. Bye-bye. Bye-bye.
Everybody.